Okay, for our second talk on the control of respiration, we're going to look at a few examples of respiratory control in health and disease. So just to remind ourselves of our objectives, you can pause the video and have a proper look. We're really just going to look at the last two groups of objectives, which is the response to physiological triggers and response to certain pathological processes. Just to remind ourselves of the inputs to the respiratory center that may have an impact on respiration. The chemomechanoreceptors, the hypothalamus, and the cerebral cortex. So then let's have a look at some conditions of health and how this might affect respiration. So the first is exercise. So even before we start exercising, the anticipation will stimulate the hypothalamus and reticular activating system, which in turn starts the process of stimulation of the sympathetic nervous system, and this has a direct effect on the respiratory center, leading to increased rate and depth of respiration. Again, in many athletes, the warm-up part of the exercise would include a voluntary increase in depth and rate of breathing. As soon as we start exercising, there's a marked increase in our minute volume, mostly through an increase in respiratory rate, but also due to an increase in the depth of respiration. And this is because of afferent signals to the respiratory center through stretch receptors in the skeletal muscle. Once these stretch receptors are stimulated due to muscular contraction and muscular activity, this information is fed back to the brainstem and increases the rate and depth of respiration. And of course, once we start exercising, the increase in the depth of breathing in particular leads to stimulation of stretch receptors in the lung. So at the height of respiration, these stretch receptors are stimulated, which leads to a cutoff. Patient breathes out and then they start breathing in again. And this is one of the triggers for an increasing respiratory rate during exercise. And finally, as our muscles start producing CO2 as a byproduct of tissue respiration, that CO2 causes an acidosis in the blood, which then leads to increased respiratory effort. So that's exercise. Let's have a look at sleep. So with sleep, there's a dampening down of the reticular activating system, and this leads to a reduction in stimulation of the sympathetic nervous system and a reduction in the automaticity of the respiratory center. We really go into a situation of automatic breathing, which is maintained at an appropriate level, because if the CO2 starts to rise or the PO2 starts to fall, our breathing will kick in. The other thing that controls this quiet respiration is the stretch receptors of the lung. So everything is now working more or less on automatic. And all of these effects impact on the brainstem nuclei. We should remember that during sleep, there are different levels of stimulation of the reticular activating system, and therefore the respiratory pattern is not steady in sleep, but it does vary. For example, between rapid eye movement sleep and non-rapid eye movement sleep, between the times that we're dreaming and the times that we're not dreaming. If you think about states of heightened anxiety or pain, it's just the opposite of what happens in sleep and sedation. There's increased stimulation of the reticular activating system with an increase in activity of the autonomic nervous system, particularly the sympathetic system, which stimulates the brainstem nuclei. And also these changes, particularly in the reticular activating system, can increase the central chemoreceptor response to PCO2, so it makes it more sensitive to PCO2. So there's a lesser rise in PCO2, causes a greater increase in respiratory rate and minute volume. Okay, let's look a little bit about disease. So let's start with acute respiratory failure, bearing in mind that this could be type 1 or type 2 respiratory failure. The patient is having difficulty breathing and gas exchange is inhibited. This will of course stimulate chemoreceptors either through a drop in the PO2 or a rise in PCO2. So that those are direct effects on the chemoreceptors, which then stimulate the respiratory center. In addition, this respiratory distress can cause an activation of the reticular activating system and the sympathetic nervous system, which again has a direct effect on the respiratory system, but also increases sensitization of the other receptors, such as the chemoreceptors. The lung stretch receptors come into play, and they are again increased in sensitivity due to the effect of the reticular activating system and the sympathetic nervous system. But also the J receptors are stimulated, and these tend to be stimulated because of irritation of the lungs. So situations such as pulmonary edema, pulmonary irritants, inflammatory products in the alveoli and bronchi. And they do increase respiration by sending signals back to the brain, which stimulate the respiratory center, but they also stimulate the cough reflex. What about chronic respiratory failure? It's a little bit different. In these patients, there's a chronic elevation of PCO2 with metabolic compensation, and that mitigates against the change in pH that you would expect both in the blood and in the CSF. Therefore, in these patients, high CO2 has much less of a stimulatory effect on the central chemoreceptors. These patients also tend to have a baseline of mild to moderate hypoxemia. In these patients, the main drivers to respiration are the chemoreceptors and the PO2. So these patients have what we call a hypoxic drive to respiration. The fact that they are hypoxic encourages them to keep breathing. The pH and CO2 receptors really only kick in if we have an acute deterioration, which leads to an even higher rise in PCO2 and a drop in pH. When we get to our case, we'll see how this becomes really important. CNS depression can be due to toxic or metabolic conditions. You may want to pause the video and see if you can work out what happens in CNS depression on the one side and brainstem injury on the other. So, with depression of the CNS due to things like drugs or liver failure or kidney failure, there's overall depression of the reticular activating system and similar depression of the sympathetic drive. Both of these reduce the sensitivity of the brainstem respiratory centers and lead to suppression of the respiratory drive. In addition, because the patient is drowsy, there is depression of the reticular activating system, and this again leads to decrease in respiratory drive, a global decrease in respiratory drive. Patients therefore become hypopneic, they hypoventilate, and they may retain CO2 and become hypoxic. Brainstem injury can lead to direct loss of function of the brainstem respiratory nuclei, and this could be complete or partial. This tends to affect the automaticity of respiration, and the pattern of breathing seen depends on which nuclei are affected. Some of the abnormal breathing patterns seen with brainstem injuries, such as brainstem strokes, include apneustic breathing, sometimes seen with pontine lesions, generally depressed respiration, or irregular respiration. Let's go back to our case. So this guy with COPD, he's a chronic smoker with COPD, so he probably has chronic respiratory illness, and often these patients have a chronic high PCO2. Remember, they would have compensated. So both the serum and CSF pH is no longer as low as it might have been with acute CO2 retention. The patient is probably getting his respiratory drive from PO2, it's hypoxia, and when we corrected the hypoxia, what we did is we took away his respiratory drive. That's why he got drowsy, stopped breathing, and his CO2 rose abruptly. When we stopped the oxygen, the respiratory drive, the hypoxic drive, was restored, so he starts back breathing, drops his CO2, and probably does wake up a bit. Okay, so that was a quick run through some clinical examples of the physiology of respiratory control. If you have any questions, you can bring them up in class. Again, in summary, we looked at the control of respiration through the respiratory center and the effect of chemoreceptors, mechanoreceptors, the hypothalamus, and the cerebral cortex in this context. Thank you.